Dear colleagues, Mr. Chairman, thank you very much for the invitation to present why I do prefer ICLs, Visian ICLs over refractive lens exchange or PRELEX in patients with high ametropia. My name is Mohammed Hosny. I'm a professor of ophthalmology at Cairo University, and I'm really indebted and grateful to Dr. Mohsen Bakkali for inviting me to share in this prestigious meeting among heavyweights like my mentor, Dr. Aliou. So, when we compare ICLs with intraocular lenses, these are devices or lenses that we use to implant inside the eye in high ametropia. So we are not talking about low ametropia, we're not talking about hypermetropes up to +4, we're not talking about myopes up to -8, and we're not talking about astigmatism in the neighborhood of up to 4 diopters of cylinder. So these are patients that do have high amounts of hypermetropia. So ICLs is very good at some times, and IOLs are very good as well in other times, and you cannot compare them to each other. It's like comparing apples to oranges. You actually sometimes you like this and sometimes you like that. So in my presentation, my short presentation today, I will try to explain my point of view why I prefer ICLs over RELEX or refractive lens exchange. Indications of both depend on the age of the patient, the type of ametropia, and the amount of ametropia, and it is a combination of all these three that defines your decision whether to implant an intraocular implantable contact lens ICL or to replace the crystalline lens of the eye by doing a phaco procedure and implanting IOL. So let's take different scenarios. In hypermetropia, of course, when I'm talking about ametropia, I'm talking about high ametropia, and these are the types of refractive errors that entail intraocular solutions. So in hypermetropia, we consider anything above 4 diopters as a high hypermetropia. So high hypermetropia above 4 diopters, if the patient is in the presbyopic age above 40 years, then refractive lens exchange, preferably with a multifocal intraocular lens, will give best results. Multifocal intraocular lenses now are becoming very, very popular, especially after the generation of trifocal intraocular lenses and the extended depth of focus intraocular lenses. The ICL in these patients is not preferred, even with a good even if you have a good anterior chamber depth, which is a little bit rare in the hyperopic above +4. But even if you have that, because the accommodation is fading, and this can be performed even without an evident lens opacity. So if the patient has a clear lens extraction, you can do a clear lens extraction, or what we call an ACLE, or an almost clear lens extraction. It's a low-risk surgery with high patient satisfaction. Multifocal intraocular lenses in hyperopic patients above 40 years are always a good solution. So, in the hyperopic patients above 4 diopters, if the patient is in the pre-presbyopic age below the age of 40. If the patient is 35 to 40 years of age, refractive lens exchange can be done if hyperopia is more than +6, and we see this every now and then. A patient with a +6 coming seeking LASIK, and the patient having an absolutely pristine and crystalline lens with no lens opacities at all. But if the patient is 35 to 40 years of age, then the best solution would be a refractive lens exchange. Again, preferably with a multifocal intraocular lens. The only thing is you have to tell the patient that he has to do the operation in both eyes, because the new generation trifocal and extended depth of focus intraocular lenses will not give the full optical potential except when implanted in both eyes. Below 35 years of age, with a clear lens, you will have an increased incidence of choroidal effusion, especially with high hypermetropia. So I actually refrain from doing surgery for patients below 35 years of age with a clear lens and with hypermetropia above +5 diopters. ICLs can be done only if the anterior chamber depth is more than 2.8 millimeters. And again, this is not something that we see every day. If you have a patient who is under 35 years of age, has hyperopia, more than 5 diopters, it is unlikely that his anterior chamber depth will be more than 2.8 millimeters. But if you have that, then you can go ahead and implant an ICL. Laser vision correction for more than +4 diopters can yield unsatisfactory results, especially if the patient has high angle kappa, and we see this every now and then. You can end up with decentrations and unmasking of latent hypermetropia, which will lead to regression. In these patients, in specific, I do LASIK extra, just lock in the effect that we do on the cornea after laser refractive surgery, and the patient will not suffer from regression. We published this before, and we know that using high irradiance cross-linking with our LASIK does make a difference in the regression arena. So high hypermetropia in the pre-presbyopic age below 40 years of age. If you have high hypermetropia above +5, +6, I definitely refrain from doing surgery, and I advise the patient to wear glasses or contact lenses. So on the other hand, on the flip side, if you have a patient who is high myope, again, up to -8, there's always a chance that you can do laser refractive surgery either by doing a LASIK, a lamellar refractive surgery, a SMILE, or a PRK, a surface ablation. But if the patient is more than 8 diopters, then refractive lens exchange is the procedure of choice if the patient is in the presbyopic age group. These patients have a high incidence of lens opacities, even if they don't have it at the present. If he's like 45 years old with a -9 diopters and does not have a significant lens opacity, rest assured that he will develop a cataract, presenile cataract, much younger than other people would develop without having the same amount of myopia. Again, these patients, they have a loss of accommodation both due to the myopia and due to the age. So there's no benefit from popping in an ICL and then depending on the accommodation of the patient to read. So I know nowadays we do have the bifocal or the multifocal EVO, but it's not, again, common practice. Although not preferably in low myopes, multifocal intraocular lenses, especially the extended depth of focus intraocular lenses, can be used after proper counseling of the patient. Again, in myopia, more than 8 diopters, if you have a patient who is pre-presbyopic, below 40 years of age, I think ICL is the clear choice. This is a no-brainer. In patients below 40 years of age with myopia more than -8, I would definitely go for ICL as a first choice. Patient still has accommodation, so will be spectacle free. Most patients with this refraction will have good anterior chamber depth, and the quality of post-operative vision is extremely satisfactory for the patient, even if he has residual myopia. We see this all the time. We see patients who are like -12, -13, even with a good amount of cylinder, like 2-3 diopters of cylinder. You pop in an ICL or a toric ICL, the patient after 1 month of surgery ends up with a -1, for example, sphere, or a -0.75 cylinder, or even a combination of a -1 sphere plus and a -0.75 cylinder. And in spite of that, the quality of vision and the amount of vision is unprecedented. The patient can see 6/6 and is very happy with the quality of his vision. So why not refractive lens exchange in these patients who are in the pre-presbyopic age and have myopia more than 8 diopters? There's been many studies reported in the literature that correlate retinal tear, posterior vitreous detachment, retinal tears, and of course retinal detachment after removal of the crystalline lens in patients with high myopia. One of these studies that was published in Ophthalmology in 2015 was a very large cohort, and these were done by all patients older than 40 years of age who underwent primary cataract surgery in France between January 2009 and December 2012. So this is a whole population of a whole country. And it had very interesting results. There was the hazard ratio of retinal detachment, which was 5.2 for age 40 to 54, 3.6 for age 55 to 64, and 1.98% for ages 65 to 74, which is basically the age that we do cataract surgery for our patients in. So if you do a patient who is 40 years of age and does not have any myopia, is an immetrope, you do have a 5% chance that this patient will develop a retinal detachment because of his age. So what about if he has myopia also? He's young and he has myopia as well. This is another study that has been published in ophthalmology on the regarding the incidence, risk factors, and outcomes of retinal detachment after pediatric cataract surgery. And in this study, they said we found that the risk of retinal detachment increased progressively with increasing myopia. Okay, so the risk, the hazard ratio for these patients below 15 years of age was 29.9%. That means actually that 1 in every 5 patients would suffer from a retinal detachment. So does myopia increase the incidence of retinal detachment post-lens extraction? Of course, classic teaching, we all know that yes, myopia does increase the incidence of retinal detachment post-cataract surgery or post-removal of the lens. But has this been proven with evidence-based medicine? And the answer is yes. Another study that was published in ophthalmology about the risk factors for retinal detachment after cataract surgery, it was found, this study said that in our study, we found that retinal detachment occurred secondary to either PVD-induced retinal breaks or holes, complicated lattice degeneration, and that after cataract surgery, PVD occurred in 77% and 87% of emmetropic eyes without preoperative lattice degeneration and with lattice degeneration. So PVD happened more in patients with lattice degeneration, respectively. Although PVD after cataract surgery itself is associated with an increased risk of retinal detachment, the risk increases multiple folds in eyes having lattice degeneration, a very common finding among myopia. So again, these patients with myopia do have an extensive chance of developing retinal detachment after removal of the lens. So I'm not happy at all doing a high myope if it is in the pre-presbyopic age, just for removal of the lens. In these patients, they do have accommodation, and I'm very happy popping an ICL in these eyes. So we all know, first do no harm, and this is our Hippocratic oath. So in a high myope, 25 years old, for example, why do a procedure that carries a risk of retinal detachment? Why take away the patient's accommodation? If you put in an ICL, the patient will have his accommodation. If you remove the lens, the patient will lose his accommodation. The risk may be acceptable if the patient has a cataract or a lens opacity, but it is definitely not acceptable if the patient has good aided visual acuity, especially when you have a procedure that offers better safety and quality of vision, namely the ICL. So a lot of doctors in our part of the world would prefer doing a clear lens extraction because of the price issues, because the EVO or the ICL is a little bit on the expensive side. But a lot of times this is actually a surgeon's perspective, and if you ask the patient, if you give the patient the choice, even if the patient looks extremely poor, he will definitely prefer doing a procedure that is much safer than doing a procedure that is much cheaper but is more dangerous. And good quality ICL wannabes are available now, and actually I have to say this, there are other types of ICLs. They are not Collamer, they are actually I think they are hydrophilic and a hydrophilic acrylic, and they are very good in the quality of vision as well. Consider the price, money, and stress that the patient will pay if retinal detachment happens. So in these patients, definitely ICL is my procedure of choice. So in high myopes, 25 years of age patient, I would definitely offer ICL surgery or no surgery at all. So this is a very simplified mind map that I do. I teach my residents and trainees that it all depends upon the age of the patient. If it is a pre-presbyopic age, if he has, of course, if he has low myopia, then I will go for LVC or laser vision correction. But if the patient is pre-presbyopic and has high myopia, I will definitely do an ICL and I will not do a refractive lens exchange. But in the same patient, pre-presbyopic, if he has high hypermetropia, I will be reluctant to do any surgery at all if he has high hypermetropia. If he has low hypermetropia, I will offer laser vision correction, or if the patient wants, I can offer an ICL as well, provided that the anterior chamber depth is more than 2.8. After presbyopia, though, if the patient has high myopia, then I would definitely do a refractive lens exchange. And if he has high hypermetropia, I would definitely again do a refractive lens exchange. And in these two patients, these two conditions, I would implant a multifocal intraocular lenses, a trifocal intraocular lenses, or an extended depth of focus intraocular lens. So IOL and ICLs, they are two good solutions, but again, they are very common in things but uncommon in other things. So you have to really choose your patient and choose the scenario where you're implanting each one. Thank you so much.